Welcome to the second part of the video on common surgical conditions in children. I hope you enjoyed part 1. This is an equally interesting video to watch. Hope you like it. Another common condition in babies is tongue tie, where the tongue folds on itself when the baby tries to bring it out. And most babies can cope with it, but many cannot even latch during breastfeeding. If they cannot latch, then they can have a simple surgery coming in the OPD, walking out with surgery, and that cures them of the tongue tie, and then they can start latching well. When should they have this surgery? As early as possible, within 15-20 days of birth, because once the child is not latching well, the mother may lose their breast milk. And that's why that surgery needs to happen ASAP. If the child has latched well and has grown to an age beyond the breastfeeding age, say 6 or 9 months of age, and they still have a thick tongue tie, then we recommend surgery at 9 months of age. Why 9 months of age? Because that the child starts using their tongue more frequently, the speech starts developing in 9 months of age. Do they really need the tongue tie to go away at that age? No. The tip only needs to be used to say t, t, d, d, n at 4 or 5 years of age or even longer. And it is really important for the tongue to clean the back of the mouth, the molars, or even the oral cavity. For that reason, the child needs the tongue tip to be free. And as a free gift, the speech also develops very well if you operate early at 9 months of age, because the child has just started learning to use the tongue. It's the best time to get rid of the problem. So either a latching problem or at 9 months is the 2 ages where we prescribe surgery for tongue tie. A very common condition all of you must have heard is appendicitis. Not everybody knows that appendicitis is very common in children. What is appendicitis? There is a part of our intestine which is blind ending. So normal intestine is from one end to the other, but between the small and large intestine there is a small worm-like piece called the appendix, and sometimes that piece of intestine gets blocked by stool or potty. It then gets inflamed. Then inflammation starts spreading to the whole of the appendix, starts getting gangrene, it ruptures, and then the pus spreads in the entire abdomen. So appendicitis definitely needs treatment. What treatment? Well, if it is very early and there is no potty stuck, like a fecalith, which means a stone made out of stool. If there are no big fecaliths, the appendix is not very swollen, and there is no spread outside the appendix, then in these early cases, we may be able to give antibiotics and treat the child. Appendicitis is complicated by these other conditions like a fecalith or spreading outside. They need surgery. What surgery? It is laparoscopic surgery in 99% of patients, and even in the worst of cases with pus also, we are able to do laparoscopic surgery very easily. The recovery is pretty fast and children usually go to school within a week after surgery. The next condition that we will tackle is pyloric stenosis. Now, pyloric stenosis is a condition where the end of the stomach, the first part of our digestive system called the stomach, the end of it is a muscle which opens and closes when the first part of digestion is complete. This muscle is called pylorus, and for some reason, we don't know why, but between 2 to 7 weeks of age of a small baby or an infant, this muscle can become very thickened and stop the flow of milk down the intestine. This is called pyloric stenosis. It causes a lot of vomiting. With vomit, acid goes out, all the salts go out, and the water goes out. So the baby becomes deficient in all these. What do? We need to admit the child very urgently. We need to resuscitate such a child. And we usually wait until all the acid, water, and salt problems are corrected before doing the surgery. What surgery? The surgery is cracking open this very thickened pylorus called pyloromyotomy. And this is usually curative, and the children have excellent outcomes with less than 2% complication rate. Once the child has had surgery, it may take a day or two to establish feeding, and there may be 1 or 2 vomits, but most children within 48 hours come back to full normal feeds. So it is a miraculous recovery back to normalcy for such children. The next condition that we will talk about is intestinal obstruction. Now, intestinal obstruction is common in children, but the cause is not one. There may be many causes. There may be tuberculosis, there may be typhoid, there may be inflammatory bowel disease, there may be previous surgery. There are many other rarer causes also. Any cause of intestinal obstruction means that the child will end up accumulating digestive juices, accumulating air, causing bloating, distension, and sometimes vomiting. The vomiting may be normal food in the beginning. It may become bilious, which is green, which is bile from our intestine. And eventually the child may lose a lot of fluid and salts and become very dehydrated. So any child with intestinal obstruction needs an urgent admission. What do? We study the cause. If it's a congenital anomaly like a malrotation or an obstruction due to atresia or any other cause of blockage, then all of the babies will need surgery urgently. If it's due to previous surgery and lot of adhesions inside between the intestines, some of them may undo themselves. And what do we do for such children? We just put a tube into the stomach to decompress the digestive system, give saline and wait for 2 to 3 days, and most such children will come out of their misery. The ones in whom the obstruction is not relieved will need surgery. Children with inflammatory bowel disease, if they develop a stricture, even if they've had successful treatment, but the intestine may heal with a stricture or a scar, and such intestine may lead to very poor growth of the child, and such children need surgery. Both for intestinal adhesions and inflammatory bowel disease, surgery nowadays is either done by ICG guided, image guided, 4K laparoscopy or robotic surgery. We hardly have to do open surgery for such children now. The rarer causes like tuberculosis and typhoid may or may not need surgery. The doctors will guide you accordingly depending on the condition of the baby. And the last and not the least condition that we are going to talk about today is hydronephrosis. With a lot of antenatal scanning where the mother gets scans done for the baby or the fetus, we pick up many children who have slightly dilated collecting system of the urine, which is called pelvis. So the kidney makes urine, it goes into the pelvis, and if that system is slightly broader than normal, that is called hydronephrosis. Hydronephrosis just means that it is structurally broad. We don't know whether the flow of urine is blocked or not, and 80% of such children will actually never need surgery, never need any intervention, but they will need some ultrasound scans once they are born. 20% of children will need very active follow-up, and many of those will need surgery. The good news, if we pick up these babies very early, preferably before being born or at least in the first 1 or 2 weeks after being born, then we can save a lot of kidneys, and a lot of factories of the kidneys called nephrons can be saved by doing early surgery for such babies. In some conditions like vesico-ureteric reflux, we defer the surgery unless and until the child gets urinary tract infections, in which case again surgery has very excellent outcomes and very fast recovery, and we end up saving the kidney. So this was about hydronephrosis, and I hope you liked listening to these topics. But if you have more topics that you want me to talk on, then please put them down in the comment section. I can make an individual video or a combo video like this, and please do like and subscribe my channel.